You're listening to Medscape's In Discussion series on cancer survivorship, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Ann Partridge, professor of medicine at Harvard Medical School, vice chair of medical oncology, founder and director of the program for young adults with breast cancer, director of the Adult Cancer Survivorship Program, and Eric P. Weiner, MD Chair in Breast Cancer Research at Dana-Farber Cancer Institute. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for use healthcare professionals.
Hello, I'm Dr. Ann Partridge. Welcome to Season 2 of the Medscape in Discussion podcast series on cancer survivorship. Today we'll discuss CAR T-cell and transplant. But first, let me introduce my guest, Dr. Stephanie Lee. Dr. Lee, who's also an old friend of mine and a mentor, is a professor at Fred Hutchinson Cancer Center and the University of Washington in Seattle. She's a hematologist and a blood and marrow transplant physician scientist who treats patients with lymphoma, leukemia, and other blood diseases who've had allogeneic stem cell transplants. Her research aims to improve the lives of bone marrow and blood stem cell transplant recipients, and she really is a maven in the field for studying quality of life in this group of patients. Dr. Lee, or I'll call you Stephanie, we've known each other so long, you call me Ann. Welcome to Medscape in Discussion Cancer Survivorship podcast. Thank you so much for being here.
Thank you, Ann, for inviting me. Looking forward to this.
Well, I've been so looking forward to this, and one of the things I like to ask when people are on this podcast is, what got you interested, not just in the field of stem cell and now CAR T-cell procedures, but studying the quality of life of these patients? How did you get there in your career?
I think that's a great question. How does anyone end up in their research niche? So I got involved in patient quality of life because I really felt like the patient experience was perhaps lacking from what we were doing. I knew I was interested in transplant. I actually knew I was kind of interested in survivorship and some of the other complications of transplant. But in terms of looking at patient quality of life and actually measuring that and understanding how that affects the patient experience and also how we determine if, our treatment is successful, not a lot was going on within the stem cell transplant field. I think part of that was because we were very focused on just getting people through, this really rigorous process. We knew that there was going to be a lot of symptoms, a lot of hits to quality of life, but we sort of justified it because, this intensive treatment would cure patients. But, there was room to think about other potential important things at endpoints. And it was also being looked at in other fields, just not in ours. So quality of life has always been something that I think is really important. And many will say, survival is the most important thing. I think when you get into the survivorship period, that's when you face a lot of these complications. And if you don't think about quality of life, you're not thinking about how to make it better, how to prevent it, how to mitigate problems. And I just saw a lot of suffering that I thought needed to be addressed.
And you have. Let's dig right in. What kinds of long-term medical issues, here we can talk about medium-term and long-term, do these patients face from transplant and now into the ever-evolving CAR T-cell treatments?
I think the spectrum of what they face is very different for those different kinds of transplants and from CAR T. But what's kind of universal with all of those procedures is that they're usually applied to people who have blood diseases, blood cancers. And so there's a lot of chemotherapy that's given beforehand, which has its own spectrum of late effects. They usually will get chemotherapy at the time of the procedure, of different intensities. And then for patients who have allogeneic procedures where they get the stem cells from the other donor types, can have graft versus host disease, which can go on and on and on and have many complications. So, what is not affected in these survivors? They have risks of subsequent malignant neoplasms, risks of infections. We know that risks of organ toxicity, so cardiovascular, pulmonary is increased. Fertility can be affected. Endocrinology, diabetes, thyroid failure, the list goes on and on. I think also for all survivors, there's this persistent potential psychological burden from having the treatment, having had the disease, from fear of relapse. And so that's another potential late complication that I think we have to think about.
Yeah, so it's essentially kind of all of medical school and medical care that these patients can need as either a complication of the cancer treatments, or just having whatever comorbidities they brought to the table to begin with. So how do you think about this in terms of, from the beginning, preparing patients for not the transplant itself, but for the survivorship phase? And when should that start?
It's sort of a philosophical question because a lot of these patients, they're right in the midst of worrying about just plain old surviving. And so the question is, when do you bring up these survivorship issues, these quality of life issues? My personal belief is that you have to start as part of the whole decision-making process to undergo these procedures. And I don't think you have to go into excruciating detail because honestly, a lot of them are focused just on the procedure right ahead of them. But when you talk to survivors, many of them are somewhat bitter and feel like they were not informed because they were not properly educated at the beginning. So I think at least opening that door and trying to assess how much they want to know and are ready to hear from the very beginning is useful. And then it's an ongoing conversation. At each phase, I think it's important to bring it up, particularly if they need to be involved in something and they actually need to participate in it versus just knowing that it's a potential risk. But our goal is to cure their disease. And if you're successful in doing that, then it is really the rest of your life. And so you have to think about these late effects and these survivorship issues. We probably pay most attention to it once the acute toxicity of the transplant is over, though, because I think that's when our patients are shifting their attention to what's going to happen now, what's the rest of my life going to be like, and they can kind of focus on it a little more.
Yeah, I think that's so salient. In our place at 1 year from the transplant, at least for the allo patients, that's when we try to navigate them into a survivorship visit. So, you really just can't handle it at the very beginning because they're just trying to manage, the very acute toxicities and when to call with a fever and things like that. So it's not just philosophical, it's kind of how much can a person bear and what will they respond to, right? Even if someone, there's too much information in too many different directions.
But there is always the person post-transplant who will say, they never told me that this was a possibility. For those people, I think at least bringing it up is really important. And again, they're not going to, as you say, not necessarily pay attention to the details, but they do have to know that what they're about to undergo has some significant long-term potential complications.
So, Stephanie, who takes care of all these survivors? And how do we care for all of these survivors? And what resources do we have for them? Okay, that's a lot of questions. How about start with the who?
Yeah. Well, I think this is a big debate in the country because, it's a good problem to have, right? More survivors. That's always a great problem to have. But who has the expertise to take care of these patients? Who has the time to take care of them? Someone who's had a history of a significant cancer, a significant treatment is not going to be your standard internal medicine type patient where you can really see them within 15 minutes necessarily. So I think that's been a big debate in the survivorship field, whether it should continue to be the subspecialist like the transplanter, should it be the oncologist, or should it be the primary care physician? Should it be in a multidisciplinary survivorship clinic, or do we have to recognize that our survivors are all over the country? So we really need to have even telehealth outreach versus more centralized clinics. So I think all of these models can work, and probably the solution differs a lot for different types of survivors and different financial and what resources people have and what expertise. I think the important thing is making sure that we do whatever we can to make sure that the survivorship stuff that needs to be done gets done by whoever's taking care of the patient. And that's a significant challenge, I think. Even at the Hutch, where we do try to see the people at 1 year and get things going, we can make recommendations. A lot of time they go back out to the community and those recommendations can't be followed, won't be followed, whatever. Here at the Hutch, we have a primary consultative mode, so we don't often take over their care entirely because we just don't have the staff to be able to do that. So we will see people who have active medical problems like every 3 months and try to give guidance. But, a lot of people are too far away, can't do that. The finances don't work for them to come back. And so then we try to work with their local providers.
Yeah, it's very, very complicated. This is where, guidelines, good communication, where that old treatment summary and survivorship care plan, in theory, could be helpful as a document to kind of pave the way, even though there's lots of controversy and uptake has been challenging. We've tried to do that at our place, but it is challenging. What kinds of resources for anybody listening who is seeing these patients in their practice and maybe the communications isn't as perfect as it could be with their treating transplanter? What kinds of resources do you recommend that person reach for? Or the patients, what do you send patients home with or refer them to for their own information?
I think there's plenty of materials out there. For patients, you mentioned the survivorship care plan, which is to us a little more of a solid tumor concept, but we sort of have that also with the transplant where we try to have guidelines. A lot of the patient advocacy groups and things have different materials where patients can understand the general landscape of when they're supposed to have different tests. And so for a patient who's really their own advocate and involved in their care, there's a lot of guidance for them to be able to work with their physician. We have to acknowledge that a lot of patients just don't have that interest or ability to be their equal partner with their physician. And so that makes that a little difficult. On the provider side, we actually have unfortunately, it's a long document about just the kinds of procedures and policies that we follow in terms of testing our survivors, and then actually, importantly, what to do with that information. When do you intervene? When do you start different therapies? But it's a lot. And, again, this is where I think that gap is. There's people who write the guidelines and who sort of see these patients all the time and think about it a lot. And then there's kind of the person out there who may not have that many of this kind of patient, and they're not going to be able to go to that document and read it. They really need or want a little bit more prescriptive information. And that's where we try to provide that, please do the DEXA in this year's, please measure the lipid panel this frequently. But maybe with our new IT tools and everybody getting a little bit more savvy about and having access to electronic things, there could be, newer solutions that we didn't have access to in the past that could make sure that people get the follow-up they need. I don't think it's such an issue, like you're saying at 1 year or even 2 or 3 years. I think the problem is when people get a little bit farther out, when that sort of experience has faded a little bit, they may not be seeing their oncologist as much or their transplant physician. And so then they're kind of out there in the more general population. And I think it would be great if we can train people, but we just have to acknowledge, even though there's more survivors, it's not like it's a huge part of someone's practice that they're going to be able to necessarily access that information and do it without some guidance.
Yeah, so when the hugs and all the casseroles go away, that people are more likely to fall through the cracks, right? The first couple of years, everybody's all hands on deck, worried about the acute-ish complications. But I totally agree. Later is when the long-term late things, that by definition, can happen. And if you're not aware, you may either have an untimely diagnosis of something, not do something you could have done to prevent, or led to additional morbidity, which is, I think, the challenge. So what are you doing or what is going on in the ecosystem in terms of research to improve survivorship care, or at least our understanding of the ramifications? And I'm particularly interested in the CAR T cells treatments because it's so new, right? Relatively. What are their issues? And who's studying that? But that's 2 questions. Sorry to do that to you.
No. I think that's great. In some ways, I think we're seeing a recapitulation in the CAR T field in the sense that, it's sort of this newer approach. They have these very acute toxicities, everyone's kind of focused on getting them through it. And then perhaps the survivorship phase is not as many people are attentive to that. They got chemotherapy, they had a disease, they often are very immunosuppressed because we have therapies that are targeted at B cells, plasma cells, and so they don't have immunoglobulin levels. One thing that is a little different, though, is the requirements that they have to be followed up for many years. And so that sort of has some built-in survivorship monitoring, whereas transplant did not. So I think people will take advantage of that. But there's still relatively few papers about the survivorship needs of people after CAR T therapies. You mentioned the sort of medium and longer term. We have a lot of people who are sort of in that medium term, but remember, CAR T is a new therapy, right? So we don't have people who are 20 years out. We have people who are 10 years out for the most part. So we may not be seeing, some of those later toxicities. So I think there's an opportunity within CAR T to not wait as long and to know that this is an issue and build it up. And so people are starting to follow their patients, more carefully, look at not just what is required for post-CAR T therapy, but what's required for follow-up of their disease and the chemotherapy and everything else. I think a lot of research is going on. There's clearly people are paying more attention to survivorship. And so I think there is a greater effort to think at the time of the treatment about what you could do to prevent some of these complications. So it used to be, it was all about just like short-term survival and short-term complications. And you're seeing the trials be powered now for like 2-year follow-up, something that includes more of the survivorship period. So a lot of effort to prevent them. There's some work going on about the best way to monitor people, how frequently to do things. Some of the stuff we talked about, like who should be monitoring them, what percentage of monitoring is being done, and if it's not, how can we increase that? And then, of course, there's always the mitigation if you actually experience the late complication or the problem, how best to treat that. But one of the problems, I think, is that the survivors are pretty spread out. It's sort of hard to get enough of them, which have the same, like we know a lot of epidemiologically what the risk factors are, but actually trying to study that is very challenging. We know cardiovascular risk is higher, but actually studying that in our survivors, getting them all together, they're so heterogeneous. How do you do those studies? That's been a little bit difficult.
And it's so hard, Dave. You're making me think about it. These people often are contributing to research by their treatment, by participating in research studies as part of their treatment. And then you also want them to participate in, long-term follow-up or cohort studies so we can continue to learn from them. And their lives have been completely disrupted from the cancer and all the treatment they've needed, whichever one it is, leukemia, lymphoma, now CARs are treating almost everything. I hope solid tumors soon. And so the question is, how do we engage our patients in a diverse pool of patients, people who come from more diverse backgrounds, especially if they're, have hits from social determinants of health? How do we help make sure that our research is representative here? We can't do it in the clinical trials. How are we going to do it in the survivorship space? Do you have thoughts on that?
Yeah, exactly what you've said. I think that, the first thing is thinking about it and having the will to try to make sure that we include people and that our results are generalizable and everything else. So I think there's that general movement and recognition in the country, which I think is also going to trickle down and help with survivorship. But we do have some unique challenges. Like you're saying, they're not coming to the cancer center every week or every, month. And so how do you do this in a more disaggregated kind of way? COVID was horrible in so many ways, but it actually might have helped clinical trials a little bit because we started realizing that maybe they don't always have to see us, that maybe outside labs are okay, that maybe telehealth is okay. Maybe you can ship medications to people. And I would love to see more of that active in the survivorship space so that we can enroll someone who has to work full time, who has a lot of parental responsibilities, who has to travel from far away in a study of survivorship issues or really any other clinical trial. So I think there's some opportunity with just how we do the trials. There's also, with telehealth, which really we weren't doing very much before COVID, and now it's a pretty acceptable way to do things. So that also might help with survivorship studies because our patients are all over the place. So maybe there will be some of those infrastructure kinds of things. But I think just as with acute care, with cancer care, with time to diagnosis, with everything else, we recognize that in survivorship care, there can be huge disparities and health equity issues. So I'm glad to see that is also being considered in our research.
And tell me, for you, what are you working on, or what I assume this is what excites you the most in the research in this area? Where do you think the next frontiers are?
Well, I think in my own personal research, I mentioned, I studied late effects of transplant. And so we're getting better. We're seeing less of that, but there's still some patients who are really affected by it. So that is my own personal, sort of focus of research. But we also, for example, every year we survey our survivors. And believe it or not, we have people who are more than 50 years post-transplant. We have people who are 10 years post-CAR. We survey them every year to kind of try and find out what the issues are. So there's lots of opportunities there. We started off this conversation thinking about quality of life and patient-reported outcomes and things. And that has always been a real focus of my research, is to try to get people to understand why that's important and to figure out better ways of measuring it, and then hopefully to actually incorporate that into our studies from the get-go so that we understand what's the total summation of our treatment on patients. And so I think we're making a lot of progress in that. But I would say that on a broader scale, that is one of the things that I'm very interested in doing. is making it almost a co-primary endpoint. It's not just survival. It's, if you look at FDA parlance, it's length of life and it's quality of life. And so just having the tools to be able to incorporate that into, how we judge success, I think would be a real accomplishment.
And you certainly have led the way for that movement, and I am just proud to know you. So today, we talked to Dr. Stephanie Lee about quality of life and patient-reported outcomes and survivorship after bone marrow transplant or blood marrow transplant and CAR therapy. And so very exciting times. Survivorship is kind of the gift that keeps on giving in a positive way for researchers, because we can continue to learn the more survivors we have and the newer therapies that create more survivors. Thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on cancer survivorship. This is Dr. Ann Partridge for the Medscape In Discussion Cancer Survivorship podcast.
Thanks for listening to Medscape's In Discussion Cancer Survivorship podcast series with our host, Dr. Ann Partridge. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on cancer survivorship.